Thank you so much. So I was asked to give this talk about, urologic aging research, and I'm going to give you the caveat that we're about to launch into that, and it really has become because of the work that we've done over the last 20 years. And I'm hoping that by the end of this, when I describe what we're hoping to do, that's where I could get the wealth of knowledge that exists on the call. To love to get your feedback, because I think it's exactly where we need to go. And I was hoping I could just share with you our history to kind of set up why we got there and why we're looking at what we're doing. So I have a PI, a co-PI that I've worked with for the past 25 years, Hunter Wessels, who was the chair of Department of Urology at University of Washington, but we've been long-term colleagues on this endeavor for a long time. And I want to kind of present to you what we've done over the last 20 years in the area. Next slide. So, for many of you probably already know this, but, it's important to kind of state that diabetes is an epidemic in the country. These numbers are already old, and they're only about a year old in terms of numbers, but they've already increased. So, more than half the population is being projected to have diabetes in this country shortly. Right now, about 30 million people do. That's about 1 in 4. And what's important to know is that the majority of the cases, 95% of the cases, are type 2, so non-insulin dependent diabetes, and only 5% are type 1, where we actually have insulin dependency. However, what's really important to know is because of all the therapeutic advances that have occurred, the majority of them are now actually living to ages where they can now be, luckily be able to experience all the other common side effects that we get for the rest of the folks who live to this age. Next slide. And what's important is as they're going through this process in aging, they will experience significant number of complications depending on how well or how poorly they control their diabetes. And so the stuff that you see in red are the things that are commonly known and are out there clinically and also in research. Obviously, neuropathy, nephropathy, retinopathy being extremely big complications. But what's been understudied and misunderstood and not clearly understood are, urologic complications of diabetes. And I've kind of highlighted here that we have focused on both bladder dysfunction issues as well as sexual dysfunction issues. And I've often thought, I will consider myself a success in my career if I can finally one day get a figure that already has these two arrows drawn in where I don't have to do it for you. But this is sort of what have been focusing on over the last couple of decades. Next slide. So I want to start with what we knew, because frankly, between 1960s to 2000, very little was done in this area when it comes to looking at urologic complications in the setting of diabetes. Things were happening, but it wasn't a whole lot. What we did know clinically is that there were associations between erectile dysfunction and what we call diabetic cystopathy, and I'll talk about that in a bit. But there are primary clinical descriptions. You see a lot of, when you try and go back to the research, a lot of book chapters in clinical textbooks, but not a lot of research actually looking at any of this in any sort of depth. And comprehensive data in humans was pretty limited at this time. And if we did have it, they tended to be quite limited methodologically. Probably around, I'd say, the late 90s and early 2000s, there were some animal models that were starting to come out in diabetes. And that was really exciting because it was starting to offer some potential insight on what may be happening. But unfortunately, the clinical paradigms weren't catching up, and they still haven't necessarily caught up. It's still a really primarily trial and error when it comes to the treatment of some of these symptoms, specifically in the diabetic population, especially because these individuals don't even normally see these patients and usually talk about these kinds of symptoms. And so really there was no evidence-based intervention or prevention approaches for this field. Next slide. And what we wanted to do was kind of address that. And it really became important to me because my research was in that last slide, in that era. And I was focused completely in the beginning of my career on BPH. And that was really my area. But I was finding in the number of publications I was putting out there was diabetes was a consistent signal. But all I had was diabetes, yes, no. Did they report it? And it was often something that we would just describe in a sentence and kind of let sit, but never really looked at. But it never went away. It was part of everything that I ever examined. And so we decided we wanted to try and do this a little bit more comprehensively, and we were invited the first time to do this in this current setting. And so for any of you who are not aware of the DCCT cohort, this was in 1983 a randomized multi-center clinical trial. The purpose of that study was to examine the effect of intensive glucose therapy relative to standard of care at the time to see if it would have any impact on complications. And I just want to kind of highlight here what was standard for treatment. So standard therapy at the time, and this was in our lifetime, at least in my lifetime, for many of you, maybe younger, maybe not your lifetime, but in my lifetime, standard of care for type 1 diabetes was 2 insulin injections a day, maybe one usually, hopefully two, to keep hemoglobin A1C levels at 13.5%. And so for some clinicians out there, you may be kind of cringing because that's just awful, right? And in fact, this is the trial that tested, should we do at least 3 to try and keep them as low as possible, like what we see in the normal population, which is less than 6%. And what they found in this trial was not even in the 10 years, within 6 years, there was dramatic reduction in complications in the intensive group. Next slide. And so what happened was they stopped the trial early. Okay, they suspended it, and all participants were then advised to continue on intensive therapy under their physician's care. And the data was published immediately. And in fact, the primary publication of this is the most highly cited paper in internal medicine in the world. And that's because it really transformed the care of type 1 diabetes. And they weren't done, which was great. And I'm glad they had the forethought at this time. Instead of letting the trial end, what they asked was all of those individuals who were participating in the trial to continue on to participate in an observational cohort study. And this is the UroEDIC study. So it's the corollary to the DCCT. And this was an observational study of the participants annually to see how they were doing with their control now that they were controlled by their physicians using this treatment that was suggested. And there were so many things that they examined. They continued to get information on complications. But what was really exciting about this long-term observational study is now we don't just get a sense of what initial randomization could have done, which is just put them in intensive therapy versus not and see what happens over time. Which is metabolic memory issues. But now we can kind of see over time, like what does maintaining good control do? Or what does lack of sustained control do? And then even what are some potential short-term effects of people with bad glucose control? And all of those things now become a possibility when we're thinking about how does diabetes now affect complications? And we wanted to take advantage of this. And so we did this in 2003. That was a first attempt, and it was an NIDDK contract at that time, where we were asked to use this study and this setting to then examine urologic complications. And then since that initial attempt in 2010, we got funded to continue, and that's been going on annually since that time. Next slide. So this is just the timeline of the study to give you a sense of how expansive it really is. The data go back to 1983 from the trial, and you can see by 1993 they closed out the trial and began the observational study, which is started in 1994 and is still going on today. And they've actually are in the process of their next set of renewals. So this is something now going 50 years, potentially. We came in 2003, we call that UroEDIC 1, our baseline assessment, got a sense of what was even happening with respect to urologic complications across the spectrum. And then based on our findings there, published a bunch of findings, we were able to get funded for then a longitudinal exploration of those things. And we were funded for a third iteration, and it's our fourth that we're going to be thinking about when it comes to aging. So we'll walk through some of that. So next slide. What I wanted to do was kind of just give you a sense of what we've collected and just a snapshot of some highlighted findings. It certainly is not all encompassed. We've published over 60 papers in this cohort. We've done a lot of research, but these are sort of the big findings that kind of give you a flavor of what we think is happening in this setting. And then I want to talk about where I think we should go. So we've incorporated a lot of assessments in this cohort, as you can see from this slide. It is not easy to get measurements incorporated into an existing study. This study has a very, very stringent data coordination center, clinical coordination center. They have 1 to 2 days of assessments every time they meet their participants. And so adding things on are not easy. And we really had to kind of think carefully about what additional data we were going to gather. So you can see here, we tried to be very comprehensive, but also used our most popular validated surveys where we could. We also do have some biologic measures. We have some serum measures. We did just recently do bladder scans to get post-void residuals. We've also done some RNA sequencing on some of their urines. And so we've tried to be thoughtful about how to try and understand systemically what's going on. Next slide. So to kind of give you a sense of what we first saw, now you have to remember, this was in 2003, okay, over 20 years ago, and these folks were less than 40 years old. They were all still in their 30s on average. And what was fascinating to see is that these folks were experiencing urologic complications relative to what we would see in the general population for people in their 60s and above. So a third of the cohort was already having urinary incontinence, clinically significant urinary incontinence. That means, multiple times per week of leakage, urinary leakage. In men, already close to half the population was saying they had moderate to severe erectile dysfunction. Again, these people are less than 40 years of age. So the complications were certainly at a level that were exceeding what we would expect to see, certainly compared to the general population. We knew it would be higher in diabetes, but this was actually quite surprising to see that they were already experiencing these things so young at this rate. Next slide. And what we did, of course, was first examine, okay, so does glycemic control impact what we're seeing? And so that was our first attempt. And what we did was look at erectile dysfunction first. And we looked to see what their hemoglobin C was at baseline when they first started the trial. Okay, so this was 20 years before this event took place and when we first measured ED. And what we found is that the hemoglobin A1C at baseline was associated with almost a 40% increase odds of ED onset almost 20 years later. So this concept of metabolic memory, meaning that early glycemic control may actually be really, really important and may be predictive of what may happen in the future. And so it's probably never too early to be thinking about these things. Next slide. And we saw that when we were looking at bladder dysfunction as well. So when you look at urinary incontinence and UTIs, we saw very significant trends with hemoglobin A1C levels and these conditions. What's interesting is the function or the measurement of glycemic control is what differed. So for urinary incontinence, what mattered was what was their summary mean hemoglobin A1C over the last 20 years. So what was that long-term control? That long-term control, if it was poor, had an impact on bladder dysfunction as represented by urinary incontinence. For UTIs, it wasn't really what happened early or what you did over time. It was what it looked like today at the time that you had the infection. So really that sort of glucotoxic event became much more important. But again, strong increase in odds, almost 40% and 20% when it comes to UI and UTIs. And this is, after adjustment for many, many factors that we know are related. So clear signals of glycemic control and some of our urologic complications. Next slide. But what's important is it wasn't always about the glycemic control, right? We actually had plenty of examples of something like this, where we had, a 43-year-old didn't smoke, hemoglobin A1C, pretty good actually, considering he's type 1, has ED. On the other hand, we have a smoker whose hemoglobin is way out of control, but is not reporting any erectile dysfunction issues. So it's not all just about the glycemic control. And this is where we really started thinking about other aspects of the diabetes experience and see what was going on there. Next slide. And so for ED, One of our first attempts was looking at hypertension. Now, there's a very well understood relationship between hypertension and erectile dysfunction. It's a little bit complicated by medication use, but regardless of the medication use, if someone is hypertensive, there is this increased risk for erectile dysfunction. And on the left-hand side, you can see we saw that very clearly in this cohort as well. So as you move from normotensive to hypertensive, your risk of incident ED increased significantly. What was interesting, though, is when we subset the analysis just to people who were normo and pre-hypertensive, so not yet meeting the clinical criteria for hypertension, we still saw that unit changes in blood pressure impacted risk of ED significantly. So even earlier on, when things haven't reached a clinical stage where someone may recognize hypertension and all the potential side effects and consequences, early blood pressure changes were starting to be indicative of something that may be happening later on. Next slide. And so we also then decided to look at all of the other sort of diabetic complications. And one thing I wanted to put out here is that probably the most important variable and signal that we are consistently seeing, and we have been seeing over the last 20 years, and is pretty much an aspect of all of the outcomes that we've been examining, is really neuropathy, specifically autonomic neuropathy. And what we see is that as we see an increase in autonomic neuropathy or cardiovascular autonomic dysfunction, or even peripheral neuropathy dysfunction, we see an increase in both ED as well as bladder dysfunction as well in both men and women. Next slide. And so this was an interesting examination. We wanted to kind of see, okay, well, those were initial snapshots, meaning a lot of them were cross-sectional. Some of them were previous historical diabetes experience with onset today. We now, over time had been collecting this data for a while. So we had the opportunity to look at things longitudinally. And so this was my epidemiologist's attempt at a heat map. I remember seeing a talk on basic science, which I understood, I think, the very first 2 slides, and then I got lost. But what was interesting was the presentation of the heat maps and what they were trying to convey. And so that was sort of what I wanted to do. I wanted to get a sense of what does it look like over time with people experiencing both ED and incontinence, and how does it look by age, and are there patterns that are occurring, or is this really random? And what we found here is that we actually detected 3 primarily big groups of individuals. You have people who never have the complication. They never get ED, they never get UI, and they're free of these complications throughout. There are people on the bottom, what we call persistent, which means once they develop it and say they got it, they always have it, and they never report not having it in our subsequent evaluations, and they stay at a more moderate to severe phenotype. And then there's a group of people in the middle, which is not an insignificant number, a couple of hundred in both women and in men, where they keep flip-flopping back and forth. They say they've got ED one time, seems to be okay the next time we see them, jumps back up another time. And so it's a sort of back and forth, and we call that the intermittent phenotype. And then when we looked at risk factors associated with these different groupings, what we found is all the traditional risk factors for ED and UI that we see in the literature: BMI, hysterectomy, our hemoglobin A1C, obesity, all of that was associated with the intermittent phenotype. For the persistent phenotype, the dominating risk characteristic was autonomic dysfunction, so neuropathy. So there is something about the persistent phenotype, and maybe it represents once you have enough nerve damage where it's pretty much done, right? I guess our question that we want to figure out next, and we need a little bit more time to do this, is do those people who are intermittent, do they eventually become persistent? Or is there an opportunity or a time window where we can actually go in and prevent some of these things from happening? Right now in the intermittent phenotype, it's possible for us to modify some of these factors, and perhaps that'll change their trajectory, but probably before it becomes a neuropathic dysfunction. Next slide. And then one of the things I wanted to point out is we've been looking at a lot of complications and glycemic control, but at the end of the day, these are symptoms that have a significant impact on quality of life. All of you are in urology. We all know this. And it's one of these things that we hear from patients and participants all the time. These symptoms are bothersome. They matter. It's what drives treatment. It's interesting, though, when you look in the field of diabetes, they just don't recognize these symptoms. It's not something they're used to even talking about, asking about, or hearing about. And what I wanted to do here was get a sense of, okay, these other complications are highly, have high significant mortality potential, significant. But let's look at their quality of life. And what we found is that the detriment to quality of life was a magnitude greater in people who said they had ED or UI compared to retinopathy, neuropathy, and nephropathy. Those are the primary complications that endocrinologists have to deal with. Yet it was the ED and the urinary incontinence that bothered them the most. So they're impacted by these complications. And next slide. I think some of that may be the age that we're seeing these. These are type 1s. They're relatively young, as you saw in the first couple of slides. They having these complications, when they're 30, 40 years old, some of them 20 years old. And I think some of that may be really, really helpful in the setting because I think we have an opportunity here to concentrate on some symptoms that may help with adherence. One of the biggest problems we have in diabetes is medication adherence. Most of the individuals, 75% of them stop taking their meds or their insulin because of just issues and side effects and how difficult it is. And so medication adherence in diabetes is a big deal. But what if we could motivate people? I can tell you right now with some of our anecdotal discussions with some of these participants, you tell a 20-year-old male that they may end up with erectile dysfunction by the time they're 30. That will have an impact on potentially having that individual control their blood sugars, maybe a little bit more so than the impending amputation at the age of 75, right? It just feels too abstract. And that's kind of the messaging that we got. So this is more than just, oh, wow, look, urologic complications exist, but is there an opportunity for this to be important in the diabetes schematic? Next slide. And so, one of the things that we've been focusing on more recently is diabetic cystopathy. And I'm going to go back to what we talked about in the 1965s to 2000s. This is what diabetic cystopathy was determined as, and this was the definition when we thought about urologic complications in diabetes, and that is that you have decreased bladder sensation, poor contractility, increased post-void residuals close to potential chronic retention, and most of the time this has to be diagnosed either with urodynamics, uroflow, or post-voids. The problem is none of these studies did that. Most of them were talking about cystopathy just with symptoms. And many of them, if they did get urodynamics, were in these very, very, very clinically samples, very, very small and convenient. So it wasn't terribly representative. And so we have to kind of go back and understand what right now we're defining diabetic cystopathy as people who have diabetes that leads to urologic complications to a flaccid, hypotonic, or atonic, essentially dead bladder. And we don't have any good information on whether that's actually happening. We know there's symptoms, but whether or not it leads to these more severe outcomes is misunderstood. And so that's something that we wanted to do. Next slide. And we did get post-void residuals in this population. And this is the first cohort in the setting of diabetes that has post-void residuals where we could get a good sense of what our reference ranges should be in the setting of diabetes. And what we found is really fascinating. It's that most of them have largely normal PVRs. It's extremely rare, less than 3% had any PVR that was indicative of any sort of retention. It does vary by gender. Men had a lot more higher post-void residuals than women. Some of that could be aging and BPH. And then most importantly, symptoms in neuropathy were most commonly associated when you saw the elevated PVRs. So most of these people, they've had diabetes for over 50 years, do not have dead bladders. They do have a lot of symptoms, but they're not at the point where their bladders are really getting there. So is that a misclassification of what diabetic cystopathy really was? We may need to rethink what our classification of diabetes-related complication actually looks like. Next slide. And so I guess I'll stop with this. It's good, got about half an hour to discuss, is what do we do next? We've done a lot of work characterizing these symptoms. We know they exist. They exist significantly, high rates. They emerge significantly. They're related to glycemic control. Diabetes severity and experience matter when it comes to these symptoms. And what we're now getting to the point is now this study is, this cohort is reaching the ages of 60s to 70s, and they're now living in an area that was previously considered unthinkable when it comes to the longevity of these patients. Most of these patients died very young. And the fact that now these are aging individuals, we really want to think about what does that mean for not only their diabetes experience, but all the complications that may then occur that are also coexisting with aging in general. So for us, what we wanted to do is really capitalize on this aging cohort, and we want to understand whether or not we see things differently in this cohort when it comes to age, specifically issues of cognition, frailty. We want to look at the long-term complication experience, metabolic dysfunctions over time, even looking at senescence biologically. So we have an opportunity to really sort of leverage this aging cohort. Next slide. And this is sort of what our framework is. And I got this framework because Scott presented it at one of the early CAIRIBU meetings, and it was a paper that I then read after he talked about it. And it talked about this concept of aging, and that there are these three sort of metrics that we think about and can group, and they each have their phenotypes and their markers that can be assessed. And there's functional aging, phenotypic aging, and biologic aging. And you can see sort of in this graph all the different kinds of things that sort of fall into those buckets. And so I took this as our guide, and the next slide is we are now coming up with a new R01 that we want to submit that's in the works, where we'll actually go through the three primary metrics of aging. So I want to look at functional aging. So we do have good data in this cohort on cognition, frailty. We've got some things on executive function, memory, and functional domains. There's been some functional limitations measurements done. We want to see whether or not the associations between these things and our urologic complications exist, and do they exist at a magnitude that may look different than what we see in the general population. We have a significant amount of information on the phenotypic aging. So adiposity, metabolic dysfunction, these type 1s now look like type 2s. And in fact, many of them are even developing metabolic disorders that the type 2 diabetes normally see because they've gained so much weight over the years. And of course, neuropathy. And now we do have some really exciting cardiovascular imaging so that we can actually look at myocardial aging. So all of this kind of talking about how do we phenotypically age, and does that impact our urologic complications? And then finally, and I'd love to get some feedback in this group because this is going outside of my comfort zone. I do have a wonderful colleague who is much more of an expert in this area, but we want to think about biologic aging and that concepts of molecular aging and particularly senescence. And we were trying to propose sort of a three-pronged approach with that. We have serum measures in this population. We have unprocessed urine that has happened at every single year over the past 50 years. And we also just in our last iteration was able to get urine measures that we processed for RNA sequencing. And so our goal was to kind of take these three different biological measures and get a sense of what types of senescence markers can be assessed with those things. So looking at serum markers for this urine, we can look at unprocessed urine proteins, things that may indicate oxidative damage, all of that. And then with the RNA sequencing that we did with the urine, our current hypothesis is that there's urothelial dysfunction, but now we can actually take those samples and see if we see any senescence markers. And so the idea is do we have sort of a systemic, look into whether aging biologically, molecularly has an impact on our complications as well. Last slide. And this is really just to thank the team. This is a huge group effort. Jeanette Brown was one of my mentors. She was at UCSF. She's the one who basically talked to me after she saw some of my papers and was like, you need to do something in diabetes. And she was the one who got me on board to getting this UroEDIC study started. And she really stuck around with us for a very, very long time, unfortunately passed during the COVID era. But, I think she'd be really proud about the 20 something plus years that we've been able to study this cohort. But I want to thank everybody from the NIH plus all of the investigators who've maintained their efforts in this study.